Λοιπόν, προχωράμε με το επόμενο τραπέζι που είναι λίγο πολύ ένα satellite symposium, το οποίο είναι από έναν από τους χορηγούς, την εταιρεία ΠΑΠΑΠΟΣΤΟΛΟΥ Varian. Έχουμε έναν ξένο ομιλητή, τον Mr. Dom Withers. Είναι συνδεδεμένος. Good afternoon, Mr. Withers. We are looking forward for your presentation. Mr. Withers is head of radiotherapy physics department at Queen's Hospital, Romford in the UK. He has more than 20 years experience in radiation oncology, and we are looking forward to his presentation, which is about the benefits of VMAT radiotherapy for breast radiotherapy planning. Mr. Withers.
Can you hear me? Can you hear me?
Yes, we can.
Okay, good. Thank you very much. So good morning from London. Good morning to you in Athens. The original title for this was Benefits of VMAT, but previous speakers have been talking about this already. And so I'm going to be looking at how we treat breasts in the UK as standard, and also as how we use the technology we have in my department. As an invited variant speaker, I'm going to be talking about our Halcyon and other products that we use. So I have a disclosure slide. Just to move on. So I'm going to talk about our department and also the UK guidelines for breast radiotherapy, which I'm sure will be very similar to the guidelines you have in Greece. Then I'm going to talk about how we treat breasts on Halcyon. It's not thought that Halcyon is as versatile as can be used for many parts of the anatomy, but we have successfully used Halcyon with breast. Also, how we are developing our breast treatment on Halcyon with VMAT and with Identify, and then the possibilities of ethos and hypercyte. So I work in a hospital in Romford, which is within London, but right at the edge of London. It's about 20 to 25 kilometers from the center of London. But there are many more NHS public hospitals in London offering radiotherapy. We serve a population of around 1 million people and have about 1,300 new radiotherapy patients per year. You can see there the breakdown of our cases, and between 30 and 40% of our patients are breast patients. So it's a very big part of our workload in our department. We went through a very fast change of our equipment a few years ago. So in August 2017, we had 3 clinics, 2 of them with rapid arc, VMAT enabled, but all of them were 10 years old and a slightly old version of ARIA. And very quickly, in the course of 1 year, we changed all of these 3 Linacs to 2 Halcyons and 1 Edge. And then later on in August 2020, one of those Halcyons was upgraded to the Ethos therapy system, which is the Halcyon platform, but is used for online adaptive. So we were the first clinic in the UK to have the Halcyon platform to treat patients. And then in June 2018, we were the first in the world to have version 2. And that's when we had the KV cone beam version 2 for Halcyon. So we were the first people to use that. And when we got our second Halcyon later that year, in October 2018, that also had KV cone beam. And that's when we started treating breasts on Halcyon, once we could do good KV quality imaging there. And coming this year, we already have delivery of Identify, which a previous speaker has spoken clearly about. That will go on all of our Linacs and in our CT simulator as well. And we are getting hypercyte on our Ethos machine, which is an improved imaging system. So to look at UK breast treatments as standard of care, this is, I haven't seen all of the conference so far, and I imagine I may be the only physicist speaking, but our standard now has become 26 grays in 5 daily fractions for breast on its own, breast or chest wall. This came right at the beginning of COVID, was very, very useful in order to be able to reduce the number of appointments that people had in the hospital. So that we cut down from 15 down to 5 for the vast majority of our breast patients. And there is, as a quote there from the paper that published it, there's no evidence or scientific rationale to argue against 26 grays in 5 fractions for any subgroup. This is just for irradiation of breast. For the boost, it's typically 16 grays in 8 daily fractions. These are both taken from the Royal College of Radiologists guidelines. There's an alternative fractionation in 5 fractions or 4 fractions as well. For nodes, axilla and supraclavicular fossa, 40 gray in 15 is still recommended. So we're not at the stage yet where we can have 26 grays in 5 fractions for the breast and nodes, and including IMC nodes, and the various scenarios you would have with that. But I've listed here 3 trials that are currently in progress to look at the possibility of using 26 grays in 5 fractions for breast plus nodes. And of course, there's Fast Forward nodal substudy, which carries on from the Fast Forward trial that gave us 26 grays in 5 fractions in the first place. For internal mammary chain radiation, this is taken from a consensus statements document from the Royal College of Radiologists. It's 7 years old now, almost, but still being used at the moment. And what I'd like to focus on here is the dose constraints for IMC. Again, you may be using similar. The only constraint for the heart is that the V17 should be less than 10%. And there are constraints for the ipsilateral lung and the contralateral breast dose, and also actually for contralateral lung. The mean heart dose of less than 6 gray is considered an objective, so not a constraint. It's recognized, of course, that it's very hard to keep the hard dose down, as previous speakers have highlighted the techniques that are available to do that. So looking at the halcyon, which is what we treat the majority of our patients on, you may not have seen a halcyon, so I'm going to describe it a little. It's slightly different from conventional C-arm linear accelerators. It really looks like a fat CT scanner. And that's a comment that patients make when they see it. And Varian worked very hard to make this machine a little bit more friendly, a little bit less intimidating. So if patients can manage their half an hour, 40 minutes treatment, preparation in a CT scanner, then they will definitely be comfortable in the halcyon, which has a 1 meter bore inside, rather than a typical 80 or 85 centimeters for CT. There's only one single energy, a 6 MV flattening filter free. The maximum field size for a single field is 28 by 28 centimeters, but you can have 2 isocenters in a plan, which enables you to treat a volume up to 38.5 centimeters long. So that's quite close to the 40 centimeter limit of traditional C-arm Linacs. The MLC is double stacked. They are 1 centimeter wide leaves, but they are offset. So the aperture is a resolution of 0.5 centimeter. So similar to the Millennium, the MLC, the Varian Millennium MLC, or the Electa Agility MLC. All imaging is done with cone beam. There is no planar imaging for KV, but it is very fast. Because it is enclosed inside the bore, there is no speed limit for the gantry to move round, and a complete cone beam can be obtained in as small as 17 seconds. And in fact, the breast scanning protocol is about the shortest, and that is the one that is 17 seconds. It is also the lowest dose protocol of all the imaging. So it doesn't have any couch rotation, which can be an issue if you want to. It means we cannot do any matched plane treatments. If you have a so-called single isocenter treatment for breast, you can't do that on this machine. There are no jaws. That's not a problem because the double-stacked MLC already provides all of the collimation required. There is no light field, so all of the setup is being done with imaging, not with a light field or with an optical distance indicator, because there isn't one of those either. The machine has no electrons either. So it feels like it might not be very versatile, but we use it for every indication in our hospital, and I say quite successfully too. When planning, there are several differences that I'd like to talk about that for the relevance for breast treatments as well. The gantry speed is up to 2 revolutions per minute during VMAT. The full gantry speed is 4 revolutions per minute. So between IMRT beams, the gantry moves very fast. It can do one rotation in 15 seconds. You can see that the gantry rotates in 17 seconds for the cone beam imaging as well. The dose rate is faster than a flat beam on a Clinac or True Beam or standard electron machine as well. It's 740 monitor units per minute rather than 600. The MLC is also faster than the Clinac and True Beam, and its transmission is very, very small. This means that when there is only MLC in the field, there is superior shielding compared with those MLCs. And this is important for doses that your organs at risk are getting. It means that your dose is more concentrated to the target and better shielded to your organs at risk when you're optimizing. Also, during optimization, those leaves can travel over the complete width, 28 centimeter field width of the field. So with typical variant MLCs, there are carriage splits for IMRT, which means that there is a 15 centimeter window at which optimization is maximized and possible. And this window is really the same for VMAT as well. So for VMAT, we also have the complete 28 centimeter field width. And to show you some of those differences, here is a target being irradiated during VMAT on the left here by an HD MLC. So this is what we have on our edge. This has 1/4 centimeter leaves in the middle sections and 1/2 centimeter leaves on the outside. And you can see that the jaws are meeting the aperture, but there is only one set of MLC shielding in this region here. So you have this leakage of around 1.5% coming through here. For the Halcyon, you can make out the 2 sets of leaves that are offset. So there in particular, you can see one leaf and then another one underneath it, and the edge of this leaf is in the middle of this one. And so that you have this 1/2 centimeter aperture, but nearly all of this aperture is being completely shielded by 2 sets of MLCs. And so the transmission is described as negligible. It's less than 0.1%. So we're doing very well on shielding our organs at risk. Another point to make about the dose coming through to the patient is that this is being treated with flattening filter free, which means that there is much, much less scattered dose from the head of the machine to the rest of the patient. A previous speaker talked about secondary cancers after VMAT and IMRT. It's not only about the dose bath in the patient, but also the dose scattered from the head of the linear accelerator. And with more monitor units compared with 3D conformal, you will have more scattered dose. With a flattening filter-free beam, certainly for at least one flattened filter-free LINAC, the scattered dose to the patient is lower by 2/3 compared with a flattened filter. Also showing you how the full over travel here. This is showing the 2 sets of MLCs again. Again, you can see there's a 1/2 centimeter aperture there. You can see, and some centimeters. But all of this, we're modulating from this side all the way to this side, which is a lot more than the capabilities of the other standard variant MLCs. So this is a picture taken halfway through VMAT. And rather than having a 15 centimeter window where we can optimize and irradiate, we've got a 28 centimeter wide window instead. So we're taking advantage of the whole field size during VMAT with our Halcyon. So to show you breasts on Halcyon, this is how we started treating breasts. So there's a few things to note of interest about this picture. First of all, we're still having our patients on breast boards at an angle. We would like to go lower, and I will tell you why whilst talking about this picture. It may seem strange as well. The isocenter here is on midline, and it is not even inside the target. This doesn't matter. Your isocenter does not have to be in the target, but you need to make sure that you cover what you're treating, of course. And the reason we do this is because the scan only reaches up to just under the chin or under the nose, depending on what we are treating. And we cannot see the elbows in the CT scan. So we do not know where the elbows are. However, when we are planning, there is this big white circle here, which represents the position of the bore of the Halcyon machine. And inside by 2.5 centimeters is a little warning circle as well. And so you must keep the couch and the patient inside these circles. Otherwise, you cannot treat the patient because the machine needs to know if the patient is going to hit the bore. If your scan does not include the whole of your patient, you need to be very confident that they are not going to hit the ball. We know that our patients go through our 80 centimeter CT scanner with no lateral movement. Of course, there's no lateral movement on the CT couch. So if we treat on midline and we know that the couch will fit down here on the halcyon, then we know that if we move them into the halcyon bore, there will be lots of room inside and they will not hit the bore as well. Before we started treating breasts on halcyon, we had some very kind volunteers who were existing breast patients on one of our clinics, and they very kindly offered to, after their treatment on certain days, to come to the halcyon to be set up as if they were being treated on the halcyon. And they were all satisfied that there was enough room in the bore. They did not feel crowded, did not feel claustrophobic, and they were comfortable. When we started treating breast on halcyon, it was we started on a week on the Friday, 2 weeks after we started treating. I suddenly realized I had had no news at all about how the breasts were being treated on halcyon, which was good news. No news in this context is good news, and there were no issues at all. And we continue to have no issues with people and how comfortable they are inside the bore and the halcyon. So as long as you can position your isocenter and the whole of your breast is within the half width of what you're treating, then this is fine. So this is why we would like to treat these patients flatter and not on a board, or maybe on a maximum of 10 degrees breast board, because that brings our couch essentially higher into the machine up to here, and it means we have the ability to move the patient from side to side and still be confident that we're not none of the patient will be touching the ball. We use sliding window IMRT. We optimize on the PTV and the lung and on the heart for left breast, but we don't treat left breasts with tangents on our halcyon, not yet anyway. This says right breast, but I think this is actually a left breast, judging from the DRR, but the principle is the same. When we do IMRT, you can see again the isocenter is outside of the target, but again this doesn't matter. We line the fields up to have a non-divergent edge down here. And this is the aperture that we will be optimizing. So we have added skin flash here manually on the fields in order to cope with any breathing. This is very traditional thing that's been done for 3D conformal planning for many decades. The halcyon from the cone beam can create these DRRs, so you can actually see how much lung and where the contour is. And of course, there's also the 3D image matching that you're doing with the cone beam itself. The treatment beam on time, I've said there, is 55 seconds. That's the total amount of time of treatment. So that's from the beginning of the first beam to the end of the second beam. Of course, the delivery is fast. This is for 2.67 grays per fraction. But also the rotation of the gantry between those beams is about 7 or 8 seconds. So it's a very, very fast treatment. A typical treatment for IMRT tangents for breast on halcyon is a walk-in and walk-out time of 7.5 minutes. So setup is very easy and delivery is very fast. This is showing what we can do with VMAT. So this is a breast nodes and IMC treatment, 40 in for the tangents, as previous speakers have said, the heart and lung doses can be too high. So we can do 3 230-degree arcs. We've done this on a limited number of cases on halcyon, only if it's suitable, really. We're waiting for gating, which is I'm going to talk about a little later. So also the beam's eye view shows you how well the MLC can optimize over the whole breast. So we're optimizing from 10 centimeters here down to another 11 centimeters here. So we have 21 centimeters wide of optimization there, almost the whole length of this breast. This is a collimator angle you would not consider with a conventional LINAC because you'd only be optimizing across a little part of it here. Really, you'd have to have plus or minus 20 or 30 degrees only for conventional LINACs. And again, this treatment time, free art is under 2 minutes. Here is an interesting case of a particularly large breast. This separation was 27 centimeters along the field-based volume here. This is a field-based volume that's been edited slightly because of the size of the patient. And we found that the halcyon plan on the halcyon plan for VMAT was better than the EDGE 10 mmV plan for VMAT. Normally, we would try to treat this 10 mV with on EDGE with tangents, but I think this was a nodes patient as well, and so we ended up treating it on halcyon, and again, treatment time very short, 1 minute 41 seconds, and very good coverage. We had better target coverage and better organ at risk sparing for our halcyon than we did for our EDGE. So later this year, we'll be getting Identify. A previous speaker spoke about this system. This is a pictures from the brochure from Identify. Our Identify is currently sitting in boxes in an empty Linac bunker, but we hope to be installing it in the next few months. We'll be installing it on our halcyon, our Ethos, and our EDGE, and also in our CT scanner. So gating is not yet fully integrated with halcyon, but we should be able to do some manual beam holding once we can monitor the patient with Identify. Full integration with halcyon is expected in a later version. So you can see how there's a breathing following pattern here, and then a breath hold, and then the system can tell you when the patient is in or out according to the region of interest that you have applied around the area that you are treating. So this is very exciting for us, that we'll be able to do a lot more effective left breast treatments on our halcyon, and we can take advantage of all the other technology that halcyon gives us for breast treatments. So we already have a very comfortable setup, plenty of room in the bore, only 17 seconds for the imaging. And of course, this speed is not just the speed of delivery. You must remember that there are no arms to deliver. There are no arms to come out from the machine holding the KV generator and the panel. This is already in place. And so you can start imaging as soon as the door closes to your bunker. So this saves, so it's more time. There's no need to deploy the arms, no need to retract the arms before treatment happens. We do tangents for breast only, but with beam on time from beginning to end is very short. VMAT for breast and nodes, beam on time is around 2 minutes. With Identify, we'll be able to do DIBH, initially with a manual beam hold, and we're looking forward to the full integration that's pending in a future version. So future prospects we also have Ethos, and we will have Identify on this as well. We will also later this year have Hypersight, and I'm going to talk a little bit about those products now as well. But Ethos is the halcyon delivery platform. You can see it looks the same, it just has different covers, and it has Ethos written on it instead of halcyon. So it takes the original planning CT and it deforms that to the cone beam of the day and creates a synthetic CT. And on that synthetic CT, there's AI auto contouring is done representing on the image of the day. And then the schedule plan that we created in planning and a new plan are both presented on that image. So there is a new plan that takes into account how the patient's anatomy is today, but also how their setup is today. So this can allow for changes in anatomy and differences in setup. So here's an example of a cone beam, a full cone beam from halcyon breast patient, and you can see in the yellow ellipse there's a difference in contour, and that difference in contour was maintained pretty much through treatment. But there are sometimes more dramatic changes in contour if you have seromas changing size, and this could be accounted for every single day to make sure you have the best possible dose distribution. So this is something we can do with Ethos if we want to do online adaptive for our breast treatments. Also, Hypersight. This is a Hypersight image, which, as I say, we haven't installed yet, but has been installed in some centers in America, and I believe in other places in Europe as well. So this looks very high quality. It is actually a cone beam. You can see that there's very, very little breathing artifact. And this representation of the top of the aorta here is a very good image of the aorta, and it's not blurred as a result of motion during a long cone beam. So it's an imaging upgrade. There are improved reconstruction kernels that limit artifacts from breathing and also metal as well. And on Ethos, it's a much larger panel. It's twice the size of the usual panel on a conventional machine, which means that you only have to half arc instead of a full arc with an offset panel. There's also improved sensitivity on the panel. And with the faster gantry speed, it means you can have a 6-second cone beam. So it's definitely possible to do very good quality cone beams in breath hold for 6 seconds. And that cone beam is also suitable for planning. That makes ethos interesting as well, because it means that rather than creating the synthetic CT, you can use that cone beam directly without having to make any deformations. That means that you, whilst there might be limits to how well those deformations can be modeled from the KV image to the synthetic CT, they will be completely accounted for in when using hypersight. So if, for example, you have a lung partially filling overnight, the synthetic CT would find this difficult to model. But of course, with a cone beam image of that, you can model it straight away. So just to summarize, we have very good patient feedback from our Halcyon patients. There is only one person who preferred a conventional LINAC to a Halcyon, and that's because he said he was an engineer and he wanted to see everything moving and everything working. But generally, our patients are happy with Halcyon. Our breast treatments on Halcyon are fast and effective. With the MLC low transmission and wide modulation gives us excellent plans, and we believe that in many cases we've had better plan quality than we have on our conventional LINACs. And of course, the speed is important for the patient. The speed is important as well for the quality of minimized movement whilst the patient is on the bed. There's no exposed imaging system, so there's no risk of collision, provided you place the patient in the right position in the first place. Imaging can start as soon as the door closes. It can be finished in 17 seconds. Then you must make sure that your radiographers are well practiced on their image matching, because this is another part of the process that can take time. But with practice, this can be reduced as well. With the potential of identifying ethos and hypersight, offers further exciting developments to enable us to give the best quality breast treatments we can. So thank you very much for listening. I think that's pretty much exactly 25 minutes. I was given half an hour, so we have a few minutes left for questions as well. Thank you.
Thank you, Mr. Vidas, for giving us insights about your equipment and the departmental practice you are using. So, you know, in the audience, we have radiation oncologists, medical oncologists, and breast surgeons. So it is clear that this was a very technical presentation, but however, you also gave us some information, and I will try to extract some clinical information here, which is that first of all, you're getting shorter and shorter in the UK, so you're treating your patients nowadays with 5 fractions. Here in Europe,
yes,
we are a little bit slower. We are still now working on the 15 fractions, because earlier we were treating with 30 fractions. So this is one information we have. And the other one is because we had a discussion before about the surrounding organs are receiving during treatment, and there was a discussion about how IMRT is getting dangerous for secondary cancers. So you gave us some information on how Halcyon and the modern radiotherapy devices are reducing the exposure of the adjacent organs. So maybe you can summarize a little bit what the advantages of the new devices compared to the older ones, just in a few sentences.
Okay, so one important thing is the flattening filter free. So when IMRT started 30 or so years ago, there was a fear that the large increase in monitor units, so that essentially the machine is on longer with IMRT compared with conformal. And of course, when VMAT came along, the VMAT reduced the number of monitor units again. It went up very much with IMRT. It came down a little with VMAT. But with when there is no flattening filter in the beam, then you have much less scatter to the rest of the patient. It was really the two things. First of all, the leakage through the MLC of the extra dose coming through, but also in the Halcyon, because the MLC is double stacked and has very low transmission, and there is no flattening filter, which means that the dose to the rest of the patient out of the field is lower than for a conventional flat beam.
Do we have any other questions from the? Thank you very much, Don, for your presentation. You told us all the platforms that Varian has, Siemens Varian has in his portfolio. A question from my side, are you using 3D technique in breast irradiation at all?
Very rarely. Our edge machine has 22 centimeter long optimizing length. Occasionally, this treat if they are lower than 20 centimeters and they are left-sided, and we want to do DIBH on our edge, then we will do that conformal. But this happens very rarely. It's only on a case-by-case basis. We would normally do IMR, sliding window IMRT for our right and left breasts on edge, and our VMAT right breasts on halcyon. And we want to move to more left breasts on halcyon once we have identified.
Thank you very much.
Okay.
Okay, thank you for being with us.